Off the Cuff, where we talk about correctional medicine and correctional nursing, and I am Dr. Minter.
And I'm Nurse Bryan.
Today we're going to talk about cows. Take the other cow. See?
Cows.
So, but these cows are not really what we're talking about.
No.
So people are like, what are you talking about? So I actually took these cows from, I live on a farm and I actually have cows. But I have a dairy cow. She's about 10. Name is Mommy Cow. And I've got her 2 offspring also. Mm-hmm. So that's why people get me cows. But cows in corrections are extremely important. So cows in corrections are withdrawal protocol for people that have opioid disorders. Mm-hmm. And it stands for something. And what does it stand for?
Clinical Opiate Withdrawal Scale.
Okay. So Clinical Opiate Withdrawal Scale. If you take the first letter off of each word, what is that?
Off the cows?
What does it mean? It means cows, right?
Right.
Yeah. So Clinical Opiate Withdrawal Scale. Right? Okay. Mm-hmm. So we use that all the time, but we use the acronym all the time. We just call it cows.
Right.
But that's what it means. Mm-hmm. And it means anybody who comes in and they've done fentanyl or any opioids out there, which there's a whole plethora full of oxycodone, et cetera. What else? Methadone.
Subutex, too.
Yeah.
Subutex.
Yeah. Mm-hmm. Buprenorphine. Mm-hmm. So whether they're prescribed or not, they come into jail, and it also depends on the jail whether they continue it or not.
Correct.
And to explain that, I do telemedicine for jails across the country, which gives me a little bit wider, I guess, farther-reaching understanding of how different jails function.
Right.
Okay. So some jails, if you come in and you're on say buprenorphine. Mm-hmm. And buprenorphine is a medication that is usually used when people, it's kind of like methadone.
Right.
People recognize methadone as when people have successfully come off of, whatever illegal opioid that they're on, and they maintain on methadone to decrease the withdrawal symptoms.
Right.
Mm-hmm. And that's what buprenorphine does. It's a little bit newer than methadone. And they're used for different things. So when they come in, or they could be on fentanyl too. Right. Mm-hmm. Which is not legal. Now. Right. That's the big one. Mm-hmm. Yeah. So they come in, and we determine, and we'll go into that as to whether they're at risk for withdrawal. Then we institute what's called cows, and not this cow. It means this scale, and we scale them and figure out whether they need more intervention or not. And why would they need more intervention when they're withdrawing from opioids?
Because of the symptoms that they'll have afterwards. They'll have diarrhea, vomiting, restlessness, increased heart rate, insomnia, tremors, a lot of different things that they can have.
Yeah, basically, they're totally miserable.
And depending on how long they've been on it for, is going to also depend on how miserable they're going to be.
Which is another reason not to do drugs. But anyway, it can also be if the jail does not continue the buprenorphine or
the
whatever.
Methadone.
Right.
Mm-hmm.
Yeah, and that's changing too. That's changing. There was the federal ADA has determined that opioid disorder or substance use disorder, and if people are maintained well, then that's really a disability. Mm-hmm. And should be continued. Now, that's starting to catch up in the corrections. Mm-hmm. Yeah, but it's not going to happen overnight.
No.
So, there was a few lawsuits that were higher profile. I think it was in Rhode Island. And they said, no, I've been maintained on this for X amount of years. I should continue to be maintained on it. And they won the lawsuit, and American Disabilities Act said, yes, that's true. Mm-hmm. So, anyway, each jail has different protocols.
Right.
Some jails have a certain set of comfort medications where they give, and we'll go into that. Some jails actually continue the buprenorphine or methadone or whatever else.
Right.
Depends on the jail. What's the risk? That's the first thing, is what's the risk for opioid withdrawal?
Gosh, well, They would, if they're vomiting, having diarrhea, they can have dehydration.
Yeah, dehydration is the biggest thing. So, because that can kill you.
Right.
So people say, oh, well, they don't die from opioid withdrawal. And they don't, like, for example, and we're going to go into, at some point, alcohol. Now, you can have seizures with alcohol or benzodiazepines or whatever, but you don't have that with opioids. But what you do have is dehydration.
Big time.
Right. And, you can have go into kidney failure, et cetera, et cetera. So that's why we have these scales. It's not just all comfort, but we have to make sure that the patient is safe. And then that will trigger a score, and we're going to go into that.
Right.
So when you come in, let's back up. All right, you're coming into intake. We explained on one of the previous podcasts what happens. You come in, get your picture taken. Assuming you're cooperative, you come into screening. You see either a nurse or, depending on the jail, you could see even a correctional officer. And then they ask you detox questions. Do you use opioids, whether they're legal or not?
Right.
And they say, all right, I'm the inmate. And I say, yes, I use fentanyl daily. So what do you do at that point?
Depending on where you work, they may or may not have the fentanyl drug screen. So what I'll do is I'll have them go to the restroom, pee, test their urine. If they're positive, that's when I would implement the COWS monitoring protocol.
Yeah.
So we can go see them on a regular basis every day, check on them, get their vital signs. I just want to add this too. It's super important for nurses to, if they were, say the deputy's like, hey, he's refusing, he doesn't want his vitals. No. Either I'm going to go to bedside and see them, or I'm going to make them get up and come to me, because those are the people who are the most sick and, like you had mentioned earlier, dehydrated, because they're not getting up for their meals, they're not getting up to drink anything, and they're the people that need to be pushed fluids,
right.
PO fluids, like by mouth.
Right, yeah, we can't say that enough is don't let people refuse until you actually talk to the person.
Right, correct.
Right, and I mean, we're going to say that over and over. Talk to the person, make sure they're okay. So anyway, they come so we test them you test them in intake, right?
Yep, we sure do, We test them there.
Yeah, and you got a little box, right?
Yeah, it's kind of funny. So I've had several, like a handful of patients where they're sitting, and then we have our, in front of them is like the desk where we've got like all of our drug screens just sitting there in boxes. And, we've labeled them like buprenorphine, methadone, and then we have fentanyl. And I've had people seriously say this. They're like, hey, can I ask you something? And I'm like, sure, go ahead. Is that really fentanyl right there? Like, is that really what it is? And I'm like, yeah, it's part of the welcome package. Yes, we give you fentanyl and we give you methadone and buprenorphine. Which one would you like? Everyone gets one. No, it's our test strips. It's just funny, though, how they, like, really believe that.
Yeah. No, you're not coming into jail and getting a gift pack of fentanyl.
No.
Yeah.
Or a mint on the pillow or whatever.
Right. So then what? So you screen them. You do the test.
Yep. And, while we're at it, and since we already have the urine, like, collected and they're being compliant, we'll go ahead and run usually the whole drug panel. We'll do, like, the 6 panel. We'll do the buprenorphine, the methadone, because so many things are mixed and cut with other things. Like, nothing's pure almost anymore.
Right.
So I'll go ahead and do it all just to make sure that they're not, taking benzos on the side as well or something like that. Or
frequently they are.
And, a lot of times they are. People don't just usually do one drug, They're trying all kinds of other things.
And, they're not made in a pharmaceutical factory either.
No.
Usually, unless they're buying a real one off the street. Mm-hmm. But a lot of it is fentanyl. We seem to have a problem with fentanyl more than anything.
Big time, yeah. It's a huge epidemic right now.
I don't
Big.
even know where it comes from. I think it comes from, overseas or something. So we put them on this scale, and you score them. So what does the scale encompass?
So usually it's got like 1 to 5 or whatever, and it will have on there, the first one will say like 0 means like they're not exhibiting whatever it may be, like restlessness or whatever. The next one might be say, restless but able to sit still for exam, and then basically it increases with whatever it may be. So like number 5 might be cannot sit still, won't, constant shifting in their seat, that kind of thing. And then you add it all up, and depending on where you work, like we talked about earlier, that's when they would implement the taper medication at that time, if need be. A lot of times in intake, we don't implement that because people aren't already detoxing. They're feeling like crap, but they're not actually detoxing yet. But they swear they are. If anything, I see alcoholics start to, withdraw quicker than the opiates.
Yeah. And you really should withdraw somewhat to actually have taper medications.
Correct.
Because they have to, you have to have like those, opened up or it's not going to work. So you have to have like a score of 6 or 8. They have to have a moderate withdrawal before you actually start buprenorphine or something else. If it's opioids, which is what we're talking about, or cows, then we give them loperamide, which is for any diarrhea. We give them Tylenol for any aches and pains. What else do we give them? We give them...
usually Zofran too, right?
Yeah, Zofran. So Zofran is a medication for nausea, and Gatorade.
Gatorade's huge.
Well, we're, in this state, in Florida, it pretty much cures everything.
Yeah.
And it actually does.
It seems to.
Yeah. So the point of the Gatorade or electrolyte solution, if you're not in Florida.
It's replenishing those electrolytes they're losing with the vomiting and the diarrhea and all that.
Yeah, and you want them to actually drink the water. So they're like, and a lot of times they're like, I don't want to drink the tap water. And then if you kind of mask it with Gatorade, I don't know if I would drink it either, then you got to get their fluids. So, all right. So if they're running high, then what do we do? They're puking.
They're puking. Well, I like to go back and see if they're even taking their comfort meds, because sometimes they're not. You'll go back in the MAR and you're like, oh, well, they haven't taken any. And sometimes they just don't know they have them available to them.
Yeah, that's true.
And they'll say, well, a nurse never told me. It just depends on who the nurse is and what facility you work at. But, and they'll say, oh, I didn't know I had that. And they're like, yeah, and they're as needed. So they wouldn't know. They wouldn't call their name and say, hey, Mr. Johnson, up here is your meds, because they're as needed. They don't call for them. I mean, in a severe case, we would go ahead and start like IV fluids, but that would be like someone who's just like not compliant with any of their comfort meds, will not drink water or Gatorade kind of thing, You
don't want them going to kidney failure.
Right.
And please don't constitute this for medical advice. Because every situation is different. But opioid use is certainly a problem. And it can take a long time. It also depends on the medication, not the medication, the drug that they were on. So some last longer methadone lasts a very long time. Fentanyl doesn't last as long.
But it's a rough start. I always tell everybody that comes in, I'm like, hey, look, because they've been like, I've been on fentanyl for a year. I'm like, oh boy. I'm like, this would be rough for you. And I let them know I'm not going to like sugarcoat anything for them. I'm going to say, you're going to have vomiting, diarrhea, stomach pain. You're going to feel like crap. I'm like, but once you're through it, you're clean. Technically, you're clean. I'm like, you just have to kind of like implement that out there. That's the hard part, is I feel like they get around those people outside, the same friends, family, whoever they're doing it with. And that's why they keep getting back on it. They're around the same people all the time. So it's a matter of getting out of that situation,
Yeah. And the thing about opioid disorders is, especially withdrawal, is that a lot of inmates or patients have done it before. They've withdrawn before. So, and this is just my opinion. Again, don't constitute it for advice, is that they've withdrawn before, and that's what they know. So when they're actually sick, they don't understand that they're sick. They think that they're withdrawing because they are. Right. But I'll give you an example. I had a guy who said, and this is years ago, he said, I'm withdrawing. I'm like, well, you came from another jail. He's like, yeah. I said, well, did you do any drugs in jail? Because it does happen. And he's like, no. I'm like, well, you're 2-3 weeks out from, I said, you can't be. And he wound up having endocarditis. So, because he was an IV drug abuser. Yeah. And I will say that endocarditis, which is infection around like the heart lining, can mimic detox, I think. It's just my opinion. But they just don't know that they're ill, or pneumonia. They think that it's detox symptoms, because they just feel so bad. Right. And that's where a good physical exam comes in, and you really got to look at the patient. You might have to run blood work on them, to see if they, what their blood work says, because it can be detox, but you got to put the whole picture together.
Yeah.
I mean, not if you've got somebody 2 weeks out, 3 weeks out, they should not be still detoxing hard like that.
I had a patient that she came in and we treated her for weeks and weeks, antibiotic therapy for endocarditis. And she promised me that she wouldn't do it anymore when she got out. And she was in jail for like a year. She got out, and I hadn't seen her in a long time. And she was, fairly healthy in the jail. She looked great. I saw her not too long ago, and she was doing fentanyl again because I did her drug screen, and I'm like, oh my gosh. But like I said, if you don't get out of that situation that you're in, you're going to keep doing it.
Yeah.
So, but it's sad because she, endocarditis is serious. That's very serious.
Yeah.
Yeah,
it's can be life-threatening.
Right.
Frequently. But when somebody says I'm detoxing, don't always take that for what it is, because it could be something else. And I'm not saying that don't take it like for anything. Don't say, well,
it's not that.
It's nothing.
Right.
Always listen to them and determine what the whole history is. So, and if the history doesn't make any sense, like the 3 weeks out or whatever else, then look towards some other things, that differential diagnosis is that it could be besides the detox. I mean, the problem is that opioid or COWS, or opioid detox, is so difficult on a human being, on their body, that it's just hard for them to even think of anything else, because they're just so miserable.
Oh, yeah.
So miserable.
They're usually, of all the different forms of detox, that's the one where they're not going to get out of bed for you when they're really bad. You have to go bedside and give them that assessment there. Mm-hmm. They're the ones that are like, they may put their arm up and be like, no, I don't want to. But that's, from a distance, you'll see that. They'll be like, no, I don't want to be seen by the nurse. But then you'll go see them, and they'll take that blanket off their head. And I've seen inmates going through opiate withdrawal where they will take several showers a day. Like, I'm talking like almost every 15 minutes just to feel okay. Yeah. And sometimes the detention deputies might get a little upset too. They're like, hey, you can't hog up the shower, but they're feeling so sick, so bad that's the only thing that any form of relief that they get is that shower. Mm-hmm. Yeah.
I had a guy who, he was fairly new to jail, and same thing. It's like, I'm detoxing. And he was vomiting, and we gave him, X, Y, and Z or whatever else we gave him, and nothing was working. And that's unusual. I mean, usually you get something to work. Right, I mean, even an injection or something. I mean, something they can stop vomiting.
Phenergan or something that it'll subside it. Yeah.
But I mean, I had to send him to the hospital, and he had another medical issue. I don't know, it was something horrible. So anyway, I don't know if it was cancer or whatever else. But I mean, that's my whole point, is that just make sure that what you're seeing is what you're seeing, that it's not something else. So that's COWS.
Right.
So COWS is very important.
It is.
In corrections. And you can find that scale online pretty much anywhere. You can just type in COWS withdrawal, and it should come up if you're looking for it. You don't need any special equipment, I can think, except for a flashlight, right, or pen light.
Right.
Right? Mm-hmm. That's all you need for it.
What, for the whole assessment?
Yeah.
There's vitals and
vitals,
pen light.
Right.
Because I think the basic stuff.
Right. Okay.
A lot of it you're seeing with your own eyes a lot of times. Like, you're actually looking for tremors. And one thing they really can't hide is, sometimes they'll pretend they're having tremors and like this, and when you're not looking, they'll stop. Mm-hmm. But when I ask them to stick their tongue out, they have no clue what I'm looking for. They think I'm asking them to stick their tongue out. But if their tongue is shaking like this, I'm like, oh, yeah. Yeah. That's a real tremor.
Well, that and goosebumps or piloerection on their arms. You can't fake that. Mm-mm. I mean, jail is cold too, so it could be that. But all right, so why don't we start? We can start a little bit on alcohol detox. Yep. So alcohol detox is another acronym, and it's CWA, but it's not S. So CWA or CWA, depending where the jail is CIWA. And that means
Clinical Institute Withdrawal Assessment for Alcohol.
Yeah. So that's the same thing, only if you come in and you're drinking too much.
Right.
So usually there's some sort of standardized scale when you come in Now, we can't test for alcohol. I mean, obviously, if you're DUI, you're probably higher risk. So we just have to ask them that.
Right.
Because we don't do any, breathalyzer
No,
or anything like that. So you ask them what?
Well, a big one is just, how much do you drink? How often do you drink? Like, what's the frequency? When's the last time that you drank? Things like that. And some jails will even have like a, it's not like a detox, it's not like a CWA per se, but it's like a screening almost to see like if you drink this many drinks this often, you should be placed on CWA. Just based off of that solely. And like you had mentioned, if you're there for a DUI, you're more likely to be placed on CWA, but just because you got drunk one night, or you know how people just socially drink,
right?
You're not necessarily an alcoholic, but if you drink every single day this many drinks, usually it's like 5, 6, 7, 8 or more. Oh my gosh, some people drink like packs. You'll definitely be placed on CWA at that time,
right?
So we'll score them there. And like I said earlier, alcohol happens so quick too, especially if you're a real alcoholic. Like you're out there, a lot of the homeless population, they're out there drinking day and night. That's all they do. They almost don't even have any kind of like real caloric intake of like food. It's just alcohol, you know, and that's why they're so skinny. So we'll assess them at that time for the tremors, diarrhea, things like that, and we'll score them out. Depending on the facility that you're at, if they score a certain score, like you said, maybe like 6 to 8, they'll implement the taper meds.
Right. Which is like diazepam
usually,
or Valium or depending on where you're at.
Right.
Some jails use Librium. There was a shortage of Librium.
Yeah, the jail I worked at before, that Librium was like the go-to for the taper for alcohol. But so basically, we look at them there, and like I said earlier, the tremors is huge, the goosebumps on their arms, things like that. But what do you look for when you look at an alcoholic coming in?
Well, same thing. I mean, whether they're, you can see whether they're shaking or not, and hallucinations.
Oh my gosh, that's huge.
So, I mean, I think if they're starting to hallucinate, that's already not a good thing.
I remember not too long ago, this happened like within the last 3 months or so. I was doing an overtime shift and I was seeing all the single cells, right? And I'm going through, and this detention deputy, I had this guy on my list to see him. And he's like, hey, you're not going to be able to screen this guy. You're not going to be able to get vitals. Like, he's out of it. And I said, open the door. They're like, okay, we told you you're not going to get it. And he was hallucinating, and he thought he had his dog in the room. And he's like, hush, hush, quiet, stay back. Like talking to the dog, And I said, oh, what kind of dog do you have? And he's like, oh, he's a pit bull mix or whatever it was. And I said, he's so cute. Do you mind if I get your vital signs? He's like, okay. And then the whole time, we're trying to do vitals. He's like, talking to the dog, like trying to keep him calm, I guess. But he was hallucinating to that extent of him seeing a dog in the room, and that was like his primary thing was to take care of this dog. That's all he was thinking about. He wasn't thinking about me being there. He didn't ask who I was. He was just in this moment with this dog. But I was able to, do an assessment and get his vital signs and all that. But they swore to me that I wasn't going to be able to. But see, sometimes you have to play along with that hallucination with them being in that. But that's huge with alcohol. I'm glad you mentioned that. Yeah.
When I had the worst one I saw was I was a hospital supervisor, so it wasn't corrections. And this, she was kind of elderly. I don't remember how. Probably not now compared to me. But anyway, I don't know. She was probably in her 60s. And I don't remember what her diagnosis was anyway. Of course, I would change it, for privacy sake, but I can't remember it anyway. So she's like, I got to go home. And I don't know, we might not have known that she was that bad of a drinker.
Right.
Sometimes they don't say that.
No.
Especially in a hospital. And so you don't keep prying like we do in corrections. We're good at prying.
We are.
Yeah. She left the hospital, but she only had a gown on. So she goes out front and she's only got a hospital gown. She's like, I got to go home. I got to blah, blah, blah. And we're like, I'm there. The nurse is there, the charge nurse is there, and then the hospitalist, physician was there. I told him, I said, you got to tell me whether she's competent or not, because we can't just grab her and drag her back into the hospital if she's competent. And, she wasn't really playing along too well. And we didn't know if she was demented or whatever else. But, you don't want her out on traffic either.
No.
So he got enough out of her. He's like, she is not competent. I'm like, okay, well, we got to get her back in the hospital. And I mean, she was just totally hallucinating. Mm-hmm. But you walk that line is that you don't want like battery on somebody, you're holding them down or whatever. But, if they're actively hallucinating, you have to determine that at the time.
Right.
That was a little hairy.
I think it's safer, like I said, to like almost play along with it. I mean, to get like what you need, like your assessment or be able to talk to them or get vitals on them.
Yeah, she wasn't going for anything.
No. Oh.
No, she wasn't playing along for, she just wanted out.
Yeah. And, she was determined.
Yeah. And probably was, like I said, I don't remember. It was probably in the middle of a workup. Maybe she already had a altered mental status. I mean, sometimes maybe the family doesn't understand that that's what the issue is.
I've actually talked to people who I had went and seen cell side for an assessment and to talk to them, and they were hallucinating. Like this one guy, he kept tinkering with the door. He was in a single cell, and he kept tinkering with it. And everyone's like, yeah, he thinks he's at work. I guess at work, I don't know if he's like an engineer or whatever, but he tinkers with stuff. And so, probably a week later, maybe several days later, I saw him and I was like, yeah, you were hallucinating. He's like, really? I'm like, yeah, you were pretending you were at work. I mean, it was like he was one person, and then after he went through that psychosis or whatever, he was a different, his normal state. And it was so weird for him to even hear me say that. He's like, oh my gosh. He's like, I really had no idea.
Yeah.
I'm like, oh, wow.
I was working at a hospital, a big hospital, which you think like nothing would happen. Big, huge tertiary care hospital. And they had a patient there who was not with it, So he, same thing, demented or, hallucinating. But same thing, like you said, he was tinkering with the door.
Yeah.
This guy, he was like a metro or like a bus driver, right, for the city. They left his uniform in the hospital room.
Oh, okay.
So he put it on.
Oh, I see where this is going.
And he left.
Yeah.
And nobody said anything. So he's not competent.
Right.
So he gets outside. So he doesn't have any money. He doesn't have his wallet, but he gets to the bus and he says, or metro or whatever, and they let him on because he's got
right. Why wouldn't they?
an employee uniform, right?
Oh my goodness.
He gets all the way home, and and his wife calls the hospital. She's like, "Hey, did you discharge Joe? Because he's here, whatever his name was, here." And they're like, "No, he's in his room." She's like, "No, he's home." He had taken like, a bus to a train or whatever, so he knew that.
Oh my gosh.
Yeah, in his uniform, they know what they know,
right?
So that it may not be everything that they're hallucinating with,
right?
Yeah. So we're at about a half an hour, so we're going to hold this podcast and we're going to continue detox next time.
Yes.
So this is Off the Cuff, and I am Dr. Minter.
And I'm Nurse Bryan.
And you can reach us at offthecuffnurses@gmail.com.